Welcome to Pulse Pressors, where critical care gets crystal clear. When perfusion falters, the body ignites two ancient rescue cascades, the vasopressin axis and the renin-angiotensin-aldosterone system. Together, they fight to preserve pressure and flow. Vasopressin, or antidiuretic hormone, is released from the posterior pituitary whenever baroreceptors sense underfill or plasma osmolality rises. It binds to V1A, receptors on vascular smooth muscle, to clamp arterioles and restore tone, to V2 receptors in the renal collecting duct to insert aquaporin 2 channels and reclaim water, and to V1B, V3, receptors in the anterior pituitary, subtly boosting an adrenocorticotropic hormone, or ACTH, and cortisol. Meanwhile, the kidneys activate the renin-angiotensin-aldosterone system. Juxtaglomerular cells secrete renin, which acts on angiotensin to produce angiotensin 1. This is then converted to angiotensin 2 by the enzyme ACE. Within seconds, angiotensin 2 constricts arterioles through angiotensin type 1 receptors, raising SVR. Subsequently, aldosterone acts genomically on the mineralocorticoid receptor in the distal nephron, upregulating epithelial sodium channel and sodium-potassium pump to retain sodium and excrete potassium. Its slower action sustains volume long after angiotensin 2's initial squeeze. The two systems synchronize. Renin-Angiotensin-Aldosterone system expands volume. Vasopressin tightens tone. In the short term, they are life-saving. When chronically overstimulated, they remodel the myocardium, thicken arterioles, and drive hypertension and heart failure. A story of survival mechanisms turned maladaptive. In clinical practice, vasopressin becomes invaluable when catecholamines plateau. In septic shock, endogenous stores deplete. A fixed infusion of 0.03 units per minute restores vascular tone without beta-adrenergic toxicity. In vasoplegia, after cardiac surgery or liver transplant, it can rescue perfusion and spare norepinephrine. Its short half-life, approximately 20 minutes, belies its sustained receptor effect. Monitor sodium and end-organ perfusion. High doses risk ischemia of the gut, skin, and myocardium. Because it acts outside adrenergic pathways, it complements rather than replaces norepinephrine. Beyond shock, vasopressin analogs and antagonists serve other fronts. Desmopressin for central diabetes insipidus. V2 antagonists, Vaptans, for SIADH-related hyponatremia, and even selective use in pulmonary hypertension, where its pulmonary vascular resistance and systemic vascular resistance profile may prove gentler than catecholamines. The RAAS side tells the same dual story: life-saving acutely, harmful when chronic. Angiotensin 2 and aldosterone sustain pressure, but long-term blockade with ACE inhibitors, angiotensin receptor blockers, or mineralocorticoid receptor antagonists prevents their destructive remodeling. So remember, vasopressin reclaims tone when catecholamines fail, and RAAS restores volume when perfusion falls. Two systems, two timelines, one goal: preserve the circulation. This is Pulse Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.